Every guideline we follow, every recommendation we trust, every clinical decision that claims to be evidence-based, all of it started somewhere, not with results, not with conclusions, but with a question. In today's episode, we explore how research ideas transform into meaningful evidence, and how systematic reviews and meta-analysis move from theory to real-world clinical impact. This episode is for anyone who has ever wondered how does research actually change medicine? And now today we are with Toka. Doctor, could you tell us more about yourself?
Hello, my name is Toka Elboraay, intern doctor, Faculty of Medicine, Zagazig University, Egypt. I started my research journey since second year of medical school, published 14 papers in international journals and 12 abstract in international conferences with a paper and article ranked in the top of 1% of article of similar age globally across all journals with also 5H index and 112 citation.
MashaAllah, doctor, you've done so much. MashaAllah, tabarakallah.
Okay, my interest in research started at a very young age. I was always fascinated about scientists and deeply curious about how they become and how they are and how their discoveries change the world. I used to read about scientists, and the more I learned about them, the more my curiosity and passion grew. During high school, this interest became more structured, and I started learning more about research, participated in research-related activities and competitions, and I joined a research team, which helped me understand how science is actually built. When I entered medical school, that passion continued. From my first year, I was actively searching for how to learn research properly and how to pursue it curiously. And being just a physician was not enough for me. I wanted to contribute to science itself and have a real impact beyond individual patient care. So this pushed me to make research and to learn and to take courses and so on.
MashaAllah, tabarakallah. I hope this journey continues and I hope you go on more and more and further and further.
Thank you.
When did you realize research could genuinely influence clinical practice?
I truly realized the impact of research on clinical practice when I studied evidence-based medicine in more depth, and specifically the pyramid of medicine. Understanding what types of study provide stronger evidence, like the guidelines and thematic review and meta-analysis, and which are weaker, was a turning point for me. At that point, I also learned how clinical guidelines are developed, and I was fascinating to see how a small study conducted in one part of the world. At the time, I also learned how clinical guidelines are developed. It was fascinating to see how a small study conducted in one part of the world can contribute to a much larger body of evidence. Researchers in different countries may study the same question, and later someone else bring all of this study together in a systematic review or meta-analysis. From that combined evidence, we extract conclusions that eventually shape clinical guidelines. That was the moment I understand that research directly forms the foundation of medical practice, and that evidence generated anywhere in the world can influence how physicians treat the patient everywhere.
MashaAllah, tabarakallah, doctor. You have such great thoughts and ideas. Um, why do you think medical students find research methodology intimidating?
Okay, of course it is the fear. Fear often comes from not understanding. The unknown is not dangerous, it is simply unfamiliar. Many medical students find research methodology difficult because anything unfamiliar tends to feel difficult and even frightening at first. When students lack exposure to research during university and faculty and so on, it becomes surrounded by a sense of mystery, and they assume it is something beyond their ability. This fear is often reinforced when they encounter the new concept. So, when they try to learn, they face new concept and complex statistics without enough hand-on experience. As a result, they step away instead of engaging. However, growth in any field starts with accepting that you are a beginner, that not knowing is the first stage of learning, far less difficult than it initially seems. So it is fear, just fear. I saw it's just fear.
I hope, inshallah, every medical student comes over their fear and continue with their great work. And now, looking back, what is one thing you would do differently at the start of your research journey?
Honestly, I wouldn't change anything. I truly value my journey as it is, with all of its mistakes and learning. Those experiences shaped how I think and grew today. However, if there is one reflection I have gained, it is understanding how fear and impatience can affect people early on. Many beginners, uh, Many beginners constantly look at the outcome, waiting for the plant to grow, or compare themselves to someone more advanced, forgetting that the main difference is often just time and experience. This mindset can be exhausting. What I have learned is the importance of listening and learning and allowing yourself to be a beginner. And this is the most important thing, allowing yourself to be a beginner. Growth should always be the priority. Learning the lessons along the way and internally development are just as valuable as publishing a paper or achieving a visible milestone. In fact, they are essential part of achievement itself. To just learn, not to publish or do a great achievement. It is also a part of the process. So whether you can reach a major accomplishment, there is always something to be proud of. If you are learning, trying, and moving toward a clear goal, loving both the process and the outcome is what truly sustains long-term growth in research and in any field.
And I hope you, inshallah, never regret anything and keep up with the great work you've done and you're doing. And now, how does a simple idea evolve into a strong, answerable research question?
A simple idea becomes a strong research question through refinement. It usually starts with curiosity or a clinical observation, but curiosity alone is too broad. The idea becomes answerable when it is narrowed, focused, and placed within a clear population context and outcome. This process we're asking why, who, and what exactly am I trying to measure? The strength of a research question comes not from how complex it sounds, but from how clearly it defines the problem and how realistically it can be studied. When you limit it to one population, one intervention, and one outcome, every time you narrow it, the turning point is when you stop asking, is this interesting? And start asking, can this be answered clearly with available data? And this also become by reading too much in the topic that you want to make the research question on it. The more you read, the more it becomes specific and you know your goal to study and start your research idea. And this is the most important step in making research. It's really the most important step.
Okay, and when is a research idea appropriate for systematic review?
Okay, this is something many beginners misunderstand. Systematic review is not chosen because it sounds advanced. It is chosen because the field already has enough study. It is appropriate for a systematic review when multiple studies exist on the same topic and the same question. Results are conflicting and scattered, so we have many papers with different results, and the clinician don't have a clear answer yet. There is no definite systematic review published about this topic and answer this question, or it is aligned. So there is a gap of knowledge here. If the literature already answers the question clearly, a review adds little value. If there are only one or two studies, a review is premature. The sweet spot is when evidence exists, many papers, but clarity doesn't. So we have many papers, but they are different in their results. So here there is a gap of knowledge that we should consider it.
Okay, and maybe this gap could be filled and the reviews could be more systematic and more medical approved.
So,
And now, how do you practically apply the PICO framework when building a research question?
okay, Waiko is not something you fill in. After choosing a question, it's something you use to test the question. Who exactly is my population? FICO is abbreviation for firstly population. So we ask who exactly is my population? And intervention I. What exactly is the intervention? Dose, duration, context. And comparator. What am I comparing it to in real clinical setting? And the most important is the outcome. Something clinicians actually care about it. Here is the key insight. If your outcome is vague, your entire review will be weak, no matter how good the rest looks. So it's really the most important part, is to read so much to specify your outcomes.
Okay, and what is the most common mistake students make when formulating research questions?
The most common mistake is starting with a question that is too broad or too ambitious. Many students want to answer everything at once, which lead to unclear objectives and weak methodology. Another frequent issue is prioritizing what sounds impressive over what is feasibly and clinically relevant. A good research question doesn't need to be grand, it needs to be specific and answerable. A focused and refined question almost always produces stronger research than an ambitious, vague one. And also make sure it is valid from registered protocol. See there is enough studies and in your topic from PubMed and just it is recent.
How does a poorly defined research question affect the entire review process?
Okay, weak research question doesn't just cause a problem later. It creates confusion at every single step. You see it immediately in the research strategy, whether too many irrelevant papers or not enough studies. Then it affects the study selection, data extraction, and even how confidentially you can interpret results. When a review feels messy, the problem is almost always the question, not the idea, not the team, and not the ethics. So it's really the most important step as it's like building something. So it is the milestone and the first stone you put. If it is good, all the process become easy and smooth.
What makes a research question both impactfully and clinically relevant?
Research question become impactfully and clinically relevant when it addressed a real problem faced by a patient or a clinician and has the potential to influence decision making. It should fill a meaningful gap in knowledge rather than repeat what is already well established. It should address outcome, what matter to patient, not just markers or statically confidential endpoint. One thing experience teach you is this. If a research question cannot influence guideline, clinical or patient care even indirectly, it may be academically correct, but clinically weak. So we should search about the gap, and we can find this gap by reading the guidelines and reading the paper and be more present in the scientific social.
What truly defines a high quality systematic review?
High quality systematic review um, is not about advanced software or complex statistics, but about consistency and transparency and reproducibility. The strongest review are those where every decision from search strategy to study selection is clearly justified and documented in the writing and the paper. A good systematic review minimizes bias at every step and allowed another researcher to repeat the process and reach similar conclusions. If a review cannot be reproduced, its quality is questionable, regardless of how polished the final papers look.
What makes a research question both factually and clinically relevant?
Okay, when it addresses a real problem faced by patient or clinician and has the potential to influence decision making, it should fill a meaningful gap in knowledge rather than repeat what is already well established. It should address outcome that matters to the patient. One thing experience teaches you is this: if a research question cannot influence guidelines and clinical decision or patient care, even indirectly, it may be academically correct, but clinically weak.
Okay, what truly defines a high quality systematic review?
Okay, high quality systematic review is defined by this discipline, not sophistication. It is not about using advanced software or complex statistics, but about consistency, transparency, and reproducibility. The strongest review are those where every decision from search strategy to study selection is clearly justified and documented in the writing. A good systematic review minimizes bias every step and allow another researcher to repeat the process and reach similar conclusion. If a review cannot be reproduced, its quality is questionable, regardless of how polished the final paper look. We can talk about the most wrong things that we can or can decrease the quality. First, not having a pre-registered protocol, such as in Prospero, or deviated from it, raise the concern about the selective reporting. Second, a weak or non-transparent search strategy, searching too few databases and not reporting search term or missing search strategy or search dates can result in missing studies. Third, unclear applied inclusion and exclusion criteria suggested by a study selection. Another major issue is relying on a single reviewer for a study screening or data extraction, which increase the risk of error and bias. We should use at least two independently. An adequate risk of bias assessment also can make or can decrease the quality of systematic review. And ignoring heterogeneity, failing to perform sensitivity or subgroup analysis and not assessing publication bias are additional red flag. Also overstating conclusion, making strong clinical claims despite low quality evidence, or confusing statistical significance with clinical importance is another common mistake. Finally, poor adherence to Prisma guideline, like missing a flow diagram or K-tables, making the review appear incomplete. In short, systematic review are rarely rejected because of their result. They are rejected due to preventable methodology weakness. Paying attention to this point can significantly improve the chance of acceptance and impact and making a high quality systematic review.
And doctor, why is protocol development essential before starting review?
Okay, because it protects the review from unconscious bias. Once you start reading studies, it becomes very easy to adjust your question or methods to fit the result you are seeing. Writing a protocol forces you to commit to your question, outcome, and method before being influenced by the literature. I see protocols as a contract with yourself, one that keeps the review scientific rather than selective. Review without a protocol often look good on paper, but lack methodological integrity.
Okay. And now, how do you design a strong and comprehensive search strategy?
A strong search strategy balances sensitivity and specificity. Early, many researchers either search too narrow and miss case studies, or too broadly and drawing in irrelevant result. Of course, use all the mesh terms and adapt strategy to each database instead of copying it blindly. This make a strong and comprehensive search strategy. Also, a good search strategy should feel slightly uncomfortable, wide enough to capture everything important, but structured enough to remain manageable.
Okay. And now, how do inclusion and exclusion criteria achieve the final conclusion?
Inclusion and exclusion criteria silently shape the conclusion more than the most people realize. They determine which evidence get a voice and which is excluded from the conversation. Even small changes in criteria, such as study design, follow-up, duration, or outcome definition, can dramatically alter the result and interpretation. This is why criteria must be defined early and applied consistently. The final conclusion of a review are often a reflection of this decision more than the data itself.
When do researchers decide to proceed with a meta-analysis?
Meta-analysis should never be automatic. It is appropriate only when studies are sufficiently similar in terms of population, intervention, comparison, and outcome. One insight that comes with experience is knowing when not to pool data. If clinical or methodological heterogeneity is high, a meta-analysis may produce a precise but misleading result. Sometimes a well-conducted narrative synthesis is far more honest and clinically useful when a forced statistical combination.
Okay, I see. And now, what separates a publishable systematic review from an average one?
Okay, what truly separates a publishable systematic review from an average one is intention and depth. Average review summarize studies, but publishable review interpret evidence. High quality review clearly justify why the question matter, explain how the evidence fit together, acknowledge limitation transparently, and discuss real clinical implication. Moral value reviews that guide thinking, not just those that collect data. Rigor and clarity and relevance are what elevate a review from acceptable to impactful. Limitation and mention everything in details in writing. As we see, as we say, limitation must become transparently, and you must, when you write, be transparent and write everything in details and describe every step.
Okay. And now, what does bias mean in the context of systematic reviews, and why does it matter?
Okay, it refers to any systematic error that led to distorted and or misleading conclusion. It occurs when certain studies or outcome or result are favored over others, intentionally or unintentionally. Bias matter because systematic review sit at the top of evidence pyramid. Any bias at level can influence clinical guidance and patient care on a large scale, making its impact far-reaching.
What are the most common sources of bias in systematic reviews?
Okay, it includes publication bias, selection bias during study, inclusion, and selective outcome reporting, and language bias. One of the most overlooking sources is bias introduced by poorly defined inclusion criteria or inconsistent screening decision across reviewers. So this led to miss articles or paper.
How should researchers assess the quality of included studies?
Okay, using a validated risk of bias tool appropriate for the study design rather than relying on subjective judgment. Quality assessment should focus on internal validity, how well the study was designed and conducted rather than on sample size or publication status alone.
And now, what is heterogeneity and how should it be interpreted?
Okay, heterogeneity refers to variation among studies in terms of population, intervention outcome, or methodology. It shouldn't automatically be seen as a flaw. Heterogeneity often reflects real-world clinical diversity. The key is to understand its sources and assess whether polling results remain clinically meaningful.
Okay. When heterogeneity is high, how should conclusions be approached?
When heterogeneity is low, conclusion should be caution and transparent. Researchers should explore potential sources, avoid overgeneralization, and clearly state the limitation. In some cases, narrative census or subgroup analysis provide more honest and useful conclusion than a bold estimate. And this is the solution for the heterogeneity and to solve it and know what is its source.
Okay. And what is trial sequential analysis and why is it introduced?
Okay, trial sequential analysis is a methodology used to control the risk of random errors in cumulative meta-analysis. It was introduced because repeated significance testing as new trials are added can increase the risk of false positive result. Trial sequential analysis apply monitoring boundaries similar to interim analysis in clinical trial to determine when evidence is sufficient.
And now, how does trial sequential analysis change the interpretation of cumulative evidence?
Okay, trial sequential analysis help distinguish between true evidence and random findings by showing whether cumulative data have crossed predefined threshold for significance. It often reveals that what appears statistically significant in conventional meta-analysis may still be inconclusive when adjusted for random error.
And now, doctor, do advanced tools like trial sequential analysis raise the standard for evidence quality?
Yes, sure. Advanced tools like trial sequential analysis raise the standard by encouraging stricter interpretation of evidence and reducing premature conclusion. However, they should complement, not replace, good study design, clear question, and methodological rigor. Advanced tools refine evidence. They don't fix weak foundations.
Okay, I get it now. And now, how can early researchers approach advanced methodologies without feeling overwhelmed?
Okay, firstly, allowing yourself to be a beginner and allowing yourself to not to know. Early researchers should approach advanced methodology gradually and purposefully. The key is to first master the fundamental before reaching to the advanced methodology. Such research design, bias assessment, and evidence census. Evidence to make sense only when built on a strong basic, learning them step by step with mentorship and practical application transforms them from an intimidating concept into useful extension of existing skills. So, firstly, should master the fundamental of research and then go to the advanced methodology and allowing yourself to be beginner. Don't forget.
And now, what is the difference between statistical significance and clinical relevance?
Okay, statistical significance tell us whether an observed effect is likely due to chance, while clinical relevance tell us whether that effect actually matter to patient or clinician. A result can be statistically significant, but clinically trivial. For example, a very small improvement that doesn't change patient outcome or decision making. True value in research comes from effects that are both statistically sound and meaningfully in real clinical context.
And now, what are the risks of overinterpreting meta-analysis results?
Okay, the main risk is drawing conclusions that ignore the quality, the consistency of underlying study. Meta-analysis can amplify bias and mask heterogeneity, or create a false sense of certainty if limitations are ignored. Pooled results should always be interpreted in the context of study quality, clinical diversity, and real-world applicability.
So how can researchers responsibly translate evidence into clinical practice?
By integrating research finding with clinical judgment, potential values, and real-world feasibility, responsible translation requires acknowledging uncertainty and avoiding absolute recommendation when evidence is still evolving. Evidence should inform care, not use it blindly.
With our very last question, what single piece of advice would you give to someone starting research today?
Okay, I advise that growth doesn't come from having all the answers, but from being brave enough to ask better questions. Also, research is a journey. Even when there is no publication yet, there is always growth, and that in itself is an achievement.
The last thing, would like to thank Dr. Tuka for her time today and answers. Thank you for everything, and thank you for the great questions that you set. Research might feel complex, but it's not reserved for experts only. Every experienced researcher once started with uncertainty questions and trial and error. If you're a student or an early researcher, listen today. Remember, strong evidence starts with thoughtful questions and careful methods. This have been Sign Up Stories. Until next time. Goodbye.